Dr. Brett Bernstein, Chief of Gastroenterology at Mount Sinai Beth Israel and Director of Clinical Integration for Endoscopy and Gastroenterology for the Mount Sinai Health System. I welcome you to this webinar on clinical documentation improvement, colonoscopy screening and surveillance interval documentation, how to get the credit you deserve. For the next 15 minutes, I will be taking you through the methods that need to be employed to be compliant with two important measures that you are already involved with at this time. One is for screening interval of 10 years in patients with a normal examination, and the other is related to the surveillance interval recommended in patients who had a previous history of adenomatous polyps. Background, all of you know by now that pay-for-reporting is being rapidly replaced by a pay-for-performance system. Appropriate documentation of surveillance and screening intervals are metrics that are aligned across three programs. MIPS, which is also known as the Merit-Based Incentive Payment System, is one of the two methodologies as of January 1st under the MACRA law that physicians will be paid under. Second is the Hospital Outpatient Quality Reporting System. The measures are known as OP 29 and 30 under this system. And finally, the ASC Quality Reporting System, under which ASC 9 and 10 are the measures. These measures will soon be published and financial penalties assessed, both on the professional and technical side. For hospitals and ASCs, data will be published on the Hospital Compare website, for physicians on Physician Compare website. And as most of you know, many healthcare systems, including ours, will be moving towards the publication of system report cards that will include metrics such as these. The penalty that will be assessed under the Hospital Outpatient Quality Reporting System are a 2% penalty on the technical charge. On the ASC quality side, a 2% penalty will also be assessed on the technical charge. Physician reimbursement under Part B Medicare under this system will be assessed with these metrics under the quality portion of the scoring system, and there's a potential 4% penalty on Part B reimbursement in 2018. Methods vary across these reporting systems. For the Hospital Outpatient Quality Reporting System, there's web-based data entry on QualityNet. This is essentially based sampling of patients from the hospital population or require full data set submission. For the ASC Quality Reporting System, there also is web-based data entry under the QualityNet system, and that is also based on sampling of an individual unit's population. Under the Merit-Based Incentive Payment System, claims or data submission through a qualified clinical data registry such as GI Quick are acceptable methods of reporting. Got from the MIPS measure description for PQRS 185, which also aligns with OP 30 and ASC 10, demonstrate that this falls under the domain of the communication and care coordination area. It is a process measure. The students of this measure are the American Gastroenterologic Association, and it is a high priority measure. The requirements for this measure are all patients aged 18 years and older receiving a surveillance colonoscopy with a history of a prior adenomatous polyp or polyps during the previous exam. Eligible patients must be greater than 18 years old on the date of the encounter. The correct ICD-10 code to be used for this examination is Z86.010. Appropriate CPT codes are listed here. The common exclusions which must be taken into consideration to comply with this metric include the use of the 5.2 and 5.3 modifiers for procedures which need to be discontinued, and 7.3 and 7.4 with relation to the administration of anesthesia. With an interval of 3 or more years since the last colonoscopy at which time adenomas were removed need to have successful documentation if the choice of less than 3 years is made. This includes that last colonoscopy was incomplete, there was adequate prep, the removal of adenomas, the last examination having had greater than 10 adenomas, a patient who is at high risk for colon cancer, presence of inflammatory bowel disease, lower GI bleeding, and a personal or family history of colon cancer. For the documentation of a system reason or reasons for an interval of less than 3 years since the last colonoscopy is mandatory if there is no medical reason. Acceptable choices include unable to locate the previous colonoscopy report or that the previous colonoscopy report was incomplete. If one chooses an interval of less than 3 years since the patient's last colonoscopy with no other reason specified, you will not get numerator credit for this choice and will potentially be penalized. Correctly, you can see here from reading the lower left box the documentation of a system reason which must include both a less than 3-year interval since the last exam and a system reason such as being unable to locate the previous report or that it was incomplete, but it cannot include a medical reason for a less than 3-year interval since the last exam. For the documentation of a medical reason to repeat in less than 3 years, this should include high risk for colon cancer, lab exam incomplete, lab exam with an inadequate prep, piecemeal removal, or that there were greater than 10 adenomas found on the previous exam. Provation electronic medical record. The matter of compliance can be guaranteed is first, you can date of the colonoscopy, and if there is no report or an unknown report, you can check this off here. For patient report is available, you will balance button. Then, personal history of adenomatous polyps and a time frame. The in frame to begin the measure include choices of greater than 5 years, 5 years, greater than 3 years, or 3 years ago. Choices for less than 3 years, which will exclude the patient from the denominator for appropriate reasons as discussed, are all here in this drop-down menu. Method is the surveillance button, followed by multiple colon adenomas, 3 or more. If you do this in this fashion, then you must select a date of the last exam. This can be done through going to the surveillance menu, checking select date of last colonoscopy, and from either 3 years, within 5 years, 5 years, or 10 years ago. Finally, the final method of doing this would be to import the date of the last colonoscopy if performed at the current facility you are performing your current exam at. PQRS 320, which is also known as ASC 9, OP29, is the percentage of patients aged 50 to 75 receiving a screening exam with no intervention, such as a biopsy or polypectomy, who had a recommended follow-up interval of at least 10 years for the repeat exam documented in the report. As before, the domain of this measure is communication and care coordination. It is classified as a process measure, and the American Gastroenterologic Association is the steward of this measure. Exclusions include patients who are age greater than or equal to 50 on the date of the encounter. The correct ICD-10 code to use here is E12.11 with CPT codes of 45378 or G0121. As before, it is crucial for modifiers as listed here to be used so that you are not penalized for a patient who had an incomplete prep, as an example. Modifiers 52, 53, 73, and 74 should be used as appropriate. Exclusions for this measure include a family history of colonic polyps, a personal history of colonic polyps, family history of a malignant neoplasm of the GI tract, and personal history of a malignant neoplasm of the large intestine. The algorithm for successful compliance with this measure is a system. To be compliant, first hit screening. Over to the menu on the right, where you can choose that the duration here should be 10 years for a normal exam. Choose 5 to 10 years we've noted. Please note that choosing 5 or 5 to 10 is classified as non-compliant. So compliance is only if placed 10 years as the recommended interval for a normal exam. Takeaway messages, penalties, and public posting of quality data are here to stay. There are no penalties if a report is unavailable or if the prep is inadequate. You just have to make sure that you document it appropriately. Finally, note patient's history, and try your best to have old reports available at the time of documentation if you're performing examinations in more than one location. I thank you for participation.